And I started to think it, probably because I got kids and I watch a lot of animated movies, I started thinking about it as a little bit of a cartoon. Well, what happened in the frames before those images? And then what happens in the frames after those images? And the reality is that in the frames before, a group of people got together and built that fence. And they created a barrier. And a group of people got together and they built those boxes. And then right before the frame for health equity, somebody came in and said, you know what, we need to build some different boxes. Because some of these folks are not getting well served by the boxes we have in place. So we either need to dismantle those boxes and build new ones, or we need to build some extra boxes upon which those folks can stand. And the thing that it says to me is that the fence and the barriers and the boxes, which are the enablers, those are conscious decisions that we make as a society. That's why we call them social determinants of health. They're social and they are determined. They don't happen by accident. And we've been making these choices for however long we've been around, 250 years. We create these things with conscious, population-based consensus decisions. And just as these fences and barriers and boxes can be built, they can be unbuilt and rebuilt. So whether it's Success by Six or the Brain Trust for Babies, whatever box you want to build, you've got to look seriously at the systems that build those boxes and the people that we work with to build them together. Because we've either got to bring that fence down or get rid of it so that everybody can participate in what's going on the other side, or we've got to build more and different and targeted boxes so that we can get folks up so they can see over that fence, right? It's one of the two. Either build some boxes or get rid of that fence. And the important thing, and the reason why I think it's an exciting time to be in public health is we get to have this conversation. And we get to think about consciously taking down barriers and consciously building enablers that will improve our health. And the thing is, for public health, especially now, as we've seen our progression into Public Health 3.0, is that we can't do it alone. The fence is too big, the boxes are too complex. We've heard about reading, right? Public health isn't going to do that alone. We can facilitate, we can build consensus, we can collaborate, we can convene. So my question to the panelists is, what are the potential stakeholders and the sectors that public health can work with to build kind of this health in all policies approach to help bring those fences down and build those boxes?
So I would recommend first, as you suggested, is that we take this as a conversation beyond public health, beyond just our traditional partners in HHS. With several of our demonstration programs at OMH, we've actually partnered with the Department of Education, with the Department with Housing, partnered with Justice, because there are several demonstrations when we're looking at, and I know CDC has a National Center on Injury Prevention, so I recognize that. But 2 years ago, when we were examining a way to address actually decreasing school absenteeism rates, addressing the rates of out-of-school suspensions, because we know primarily by the time when we look at urban areas and public schools, and we look at the disparity of rate of suspensions with African American and Latino males, what we see is in some cases a twofold or threefold rate in terms of the disparity. And so with designing or developing the demonstration and the funding opportunity announcement, we partnered with the different agencies that traditionally, when we build these demonstrations, we generally talk to each other and that can be great, but this problem has grown bigger. And we really need to work with some of the other policy experts in the area and the evaluators to identify what's currently being funded out there, where are some of the other challenges, and be able to build those partnerships so that we have joint announcements and we can actually build much stronger programs, and we can assist the projects, the communities that we fund, to actually have a more robust program or intervention, but also to ensure that when the funding ends for the project, that one, the communities, one, own the data. That's very important. Secondly, that the projects are structured so that they can continue, maybe not the entire project in its entirety, but perhaps what the essential elements are, and that we leave the community in a better place than when we started. So it's...
I'll add to that with what we've always done under the leadership of Dr. Fitzgerald at the Department of Public Health was look at our approach always as a public-private partnership, because we know we can't do a lot of this work alone. So we started that with our Georgia SHAPE initiative, which was the Governor's Childhood Obesity Initiative, and then that continued into work like the Brain Trust for Babies, and looking at kind of traditional partners, but then also untraditional partners like the Department of Juvenile Justice. We work a lot with early care and learning, what you'd think of tradition as a daycare. Faith-based communities and advocacy organizations, which are, I think, critical, especially when you're thinking of yourself, if you're a government agency, we can't always go over to the Gold Dome and advocate for policies that are good for babies and good for children. We provide data, we can show that it's good, we can't advocate. So having those relationships with advocacy organizations, the ones who can really go down there and get in front of legislators and help move stuff along, move policies along, I think are critical in this kind of work.
Yeah, I think it's interesting and just emblematic of some of the changes happening out in the field. We have been working closely with a major Midwest city on some of their policy initiatives. And the latest two priorities for the health department in the city was, number one, changing the enforcement mechanisms for their housing code. And this is the policy head, this is the head of policy for the health department in the city, working on the enforcement mechanisms for the housing code. And once they worked on that, the next one was payday lending. That's coming out of the health department. So working cross-sector analysis, there's research, there's a really good paper that came out late last year. Some of you are probably familiar with a guy by the name of Glenn Mays, works with the University of Kentucky. And he and a team looked at how jurisdictions were working cross-sector, and came up with the metrics to determine the extent and the quality with which that collaboration was taking place, and found statistically significant positive health outcome effects by jurisdictions that work across sectors. So this idea of collaboration and working with non-traditional partners for public health, I think, can have real-world impacts, and hopefully bring health equity to the forefront. So I know that's time. I think we're right at time. So I don't know I think we're done. Yeah.
Okay, I know we are kind of out of time, but I would like to ask quickly if our panel presenters could come up to the table. We know we haven't had time for any Q&As from the audience, but we would like to just have just a few minutes for any final Q&As from our audience. I would like to ask our current panel, our 6 panel members, to come back up. Yes. And you may have to share the mic. So the floor is now open for any questions for our 6 panel members. It doesn't matter where you sit.
Good afternoon. My name is Fentress Trucks, and I'm with the Diversity and Inclusion Management Team here at CDC in the Office of Minority Health and Health Equity. I wanted to say, way to go, Dr. Bird, another great forum. I learned a lot here. And my question, I was looking at the mortality rates, and I guess about in 2008 when I was sitting in Arizona, and Arizona started to embrace diversity and inclusion, one of the things that came out that was a catalyst was the public health department talking about mortality rates, particularly for not only adults, but in hearing the morticians talking about the death of babies. My question to you, I heard you, I believe Dr. Jerry, talk about working with institutions, hospitals, but I'm not hearing you all talk about anything of what you're doing with the workforce that's in these hospitals that are treating all kinds of patients. And if that possibly is something we need to focus more, not only from a D&I perspective, which I'm already clued in that we need to, but are you seeing any studies or anybody talking about work that needs to be done to help people deal with patients that are coming in with cultural differences that may dress different, may look different than you, and why they're treating those patients differently instead of a gold standard for everybody?
It's a great question. There is something called the class standards, culturally linguistically accessible services, which comes out of HHS, and any institution that accepts federal dollars is supposed to have implemented these. I don't think they're enforced at all, but they are getting at what you're looking at in terms of interactions with patients. But overall, I think the first thing each of us needs to do is look at our institutions, and are we diverse and inclusive? That's something we're starting to undergo in the March of Dimes, because historically they had a history of promoting from within and keeping people for 30 years, and therefore the workforce sometimes looks like the workforce of 30 years ago. So very deliberate efforts to become more diverse and more inclusive. So we all have to do it. We have to make sure that there are programs to move people from communities into these roles so that they are culturally sensitive, they know the community, and I think, I'm not an educator, my wife's a health educator, there are a number of programs supporting bringing underrepresented students in and providing, when necessary, support services to them to make it through, but we're not doing nearly enough, and I don't.
May I just add something to that? So we're in the Bronx, and I'm the minority as a white person in the Bronx, and our workforce reflects our patient population, and some of the worst interactions occur between a Puerto Rican and a Dominicana, right? And from our perspective, they're both Latina, and they understand each other's cultures, and just having a diverse workforce, it's a piece of it. But I think what we're now starting to call trauma-informed care is a really critical secondary piece of it. Helping folks understand how critical those interactions are, and trying to change the conversation from what's wrong with you to what happened to you, and understanding vicarious traumatization and all those things, because we're seeing a lot of really difficult interactions within cultures that goes deeper than just getting the right group in the room. It's also then training them and giving them some self-care techniques and some understanding of the impact of that relationship.
Thank you all for your servant leadership work, too.
My name is Tara Harlan. You have to excuse my voice. But for Ms. Cobb-Saucer, you were talking about the different programs that you all have in Alabama and how prominent they were. What are the possibilities with all the budget cuts of these programs being implemented through Georgia in the rural areas? How do we implement programs such as these in a rural area? And I know Georgia's the banner, but a lot of the rural area have gone satellite, and all the major like family and children programs, they're the major office are in the larger city in the parameters of the rural area. So how do we get these promoted in the rural areas with all the budget cuts? Where does this funding, how do we find this funding?
So I'm going to provide some suggestions, and I wouldn't be able to speak to the budget, the current federal fiscal budget. But let me just say that in terms of our funding opportunity announcements, when we actually develop them, we take into consideration that we're going to receive a huge response from both urban areas and what we refer to as mixed, and also those micropolitans, the smaller areas, the rural areas. And we ensure that when we develop that set of standards and the requirements for applicants, that we develop them with specific indicators and specific descriptions so that an applicant that's coming in for a rural area will also have a chance to compete fairly with that from an urban area. The most recent example is that our office was asked by the Secretary to develop a funding opportunity announcement for this past fiscal year, fiscal 2017. And we were tapped in the spring, which I believe late April of this year, to develop this announcement to actually fund communities to address the three focus areas. First being opioid abuse or opioid overdose. Second, to address childhood and adolescent obesity. Third, serious mental illness. Now, while we developed indicators for each population and communities, we knew some things, and that is, with my tapping my colleagues from various centers at CDC and from SAMHSA and also from HRSA, that not all cities and not all states report overdose rates. Okay, first, so that if we had designed the FOA, and I'm just using this as an example, if we had designed the FOA where an applicant would have to actually report their overdose rates based on X per population, then the chances would have been greater that only the urban areas would have been able to come in because of the reporting, and they could validate those rates. For rural areas, we provided them with examples of other sources of data and the type of information that they could submit so they also could compete. Now, we did that for opioids and also for childhood obesity. And so out of the 8 childhood obesity projects that were funded, and they're for young children, I would say that close to half, if not greater than half, are serving a population that's more rural and not your larger urban areas. So that's just one example. I wouldn't be able to speak to the state decisions in terms of their determination of which focus area and which geographic population that they would like to select. But what I can say for many of the state partnership initiative grantees, what they did is actually identify urban area and also a rural area because they understood the challenges of those rural areas. And in many cases, a contract that they could engage in with a local health department or a community health center or a federally qualified health center of an amount of $50,000, that investment in a rural area can go much further than it can with an urban area where you're competing with multiple priorities in that setting. So I don't know if I've answered your question, but I can't speak specifically to, budget cuts, whether at
You did answer my question.
Right.
And with that being answered, would that go through our city councilor, our family children services? What government integral at the local level that I would reach out to contact to see if any implementations can be taken?
So I would say as a federal staff person, we first have to be mindful of what restrictions we may have when it comes to advising, informing, advocating for, or encouraging non-governmental entities to compete for competitive funds.
Yes, ma'am.
So in our office, we have a resource center, and so we encourage people, that last slide that I had up, there's a link there. And so we encourage members of the community to sign up for newsletters and for electronic updates, because not only do we send out e-blasts for federal funding opportunity announcements, there are also announcements for funding from foundations, and also there they're combined announcements. So that information goes out in terms of the HHS funding forecast for the fiscal year. We send the electronic updates out to everyone that signed up on the list. We include it in newsletters, and we also post it to our website. So if there are persons in the community that you work with, I would strongly urge you to have them to sign up for the e-blast, make them aware of the HHS grants forecast, and then from there, I would say you'd want to consult your supervisor or those higher up in terms of what are the next steps. But we just have to be mindful of our role when we are advising and informing the communities, whether or not it goes beyond that, sharing that information, and directing them to take some other advocacy type
Thank you
role.
so much.
Okay.
Do a final big round of applause for all of our presenters.
So I want to ask all of us who remain to stand because you made it through a lot. When we plan these forums, we we're always, we know we want to get a certain amount of things covered. We know it's extremely difficult to hold CDC people for like a whole day, especially when we're at home, because the office, the temptation of going back to the office or maintaining your regular schedule is always there. So I want to thank everyone who is here. I see our dear colleagues, Dr. Richardson and Mildred Thompson with the Health Disparities Subcommittee. We mentioned you all earlier today. Welcome, welcome. But I just want to thank our presenters. We were able to pull in today the leaders in this field, and they made a lot of adjustments to their schedules to be here, and I deeply appreciate that. I always appreciate my colleagues from CDC who come, no matter, we call, we said, can you help? They always say yes. And so I want to publicly thank them. I want to thank Colleen Boyle for being here and for her participation. Yes, yes. And so anyway, with that, I just want to bid everybody farewell, stay well. We'll see you again next year. And I want to thank all my colleagues in the Office of Minority Health and Health Equity who rallied to bring today together, and a special thanks to Captain Wilkins, who has steered us to this day from the beginning. So thank you so much. Thank you, everybody.